So, good evening. My name is Lauren Dawson. I'm from the University of Ottawa in Canada. Just a note, there are two authors missing on my abstract in the booklet. There's also Andrew Post, as well as my supervisor, Dr. Hoshizaki. So I will be doing my study today on impact characteristics causing persistent concussive syndrome in youth. So currently, concussions, or mild traumatic brain injuries, are one of the most talked about injuries within sports today. Concussions are diagnosed by symptomology such as headaches, dizziness, nausea, a sensitivity to light or noise, and in some severe cases, even a loss of consciousness. Over 1.5 million cases of traumatic brain injuries are reported every year within the United States. Of 75% of those are categorized as mild traumatic brain injuries. Additionally, almost 500,000 mild traumatic brain injuries in youth have been seen and are diagnosed each year, with falls being the leading cause of injury. So these mild injuries are often transient, with symptoms resolving within 7 to 10 days. However, in 15% of these cases, persistent symptoms have been associated with this injury. This is then often classified as persistent concussive syndrome. This syndrome is considered a serious brain injury that with potential serious side effects such as a decreased mental functioning, depression, anxiety, and migraines. The effects of this injury on children, however, may be more detrimental as they are in a stage of learning and brain development. Additionally, if they also endure persistent symptoms, it could impact their academics, as they would spend more time away from the classroom. This would then have a significant effect on a child's well-being and could further cause mental illnesses such as depression and anxiety. So to begin, what historically are the issues involved with this specific injury? So because of the large amount of media attention on concussions in sports, especially within the professional leagues, multiple sporting organizations have developed educational programs such as Return to Play or the Heads Up program, as well as rule changes to diminish the chance of injury across all levels of sport. However, there is often a disconnect between these programs, as the definition of concussion is still not well defined or fully understood. This raises many issues, but the main issue is determining whether mild traumatic brain injury or concussion is a single injury, or is it a range of injuries that ranges within severity. One could argue this, as you could see that there are some cases with transient symptoms and some with persistent symptoms. Therefore, should those be categorized as two separate injuries? So of these issues, where are we today and what has been learned and concluded? So firstly, there's been a consensus group of specialized individuals that have been assigned to come together to determine a definition of concussion. So they've agreed upon a general definition, which states that a concussion is a clinical syndrome involving a disturbance in the brain function that is generally time-limited and results from biomechanical forces. However, there is no agreed-upon definition of a transient versus a persistent concussion. And additionally, there are no specific agreed-upon guidelines between those two injuries. However, there are some guidelines out there, such as the Ontario Neurotrauma Federation, which has some suggestions for persistence, but within adults and children. So from these consensus meetings, the Return to Play guidelines were developed, but however they were based on mainly adult data. None of these guidelines were based on children's data because there are very few studies currently looking at children with concussions. So additionally, these management techniques were more developed for transient symptoms and are lacking guidance for persistence as well. For this reason, more data needs to be collected for persistent cases in youth to assist us in understanding the differences in the conditions and the risks associated with each age category. Currently, there has been a study conducted where it reconstructed adult PCS cases. However, youth has yet to be examined. Therefore, what is left to be done with this topic, and where do we go from here? So what needs to happen is we need to create a return to play, management, and treatment programs for specifically transient and persistent symptoms based on research involving youth concussion. This is very important as we know that there are differences in the children and adults in terms of anatomical, physiological, and behavioral differences. And this may limit the effectiveness of the risk management programs for youth. The youth may possibly be more susceptible to persistence at different thresholds compared to adults because of a difference in brain tolerance. This could be associated to the differences in the physiological responses to mechanical stress, different geometry of the skull and the brain, as well as structural component properties of the head, such as a white-gray matter. So for this reason, the true risk of concussion in youth is still unknown. So what we want to determine is what could cause a unique risk for concussion in kids. Therefore, we need to understand what influences this risk, especially the risk of persistence versus transient. So impact variables can be then examined to determine their influences on the injury. The impact variables are the impacts of the injury, such as the inbound mass, the mass of the head, and the surface compliance. So these variables may have an effect on the injury, but we also want to determine the relationship between the variables. So, for example, the relationship between mass and velocity. Therefore, as you can see, the F equals ma equation would state that there is a relationship explaining that if mass and velocity, such as a small child, therefore falling from a smaller height and with a smaller head mass, would decrease their acceleration as well. For this reason, you can look at linear and rotational acceleration to determine if this is the correct relationship. So this leads us to the question that if there is a decreased acceleration in youth, does this prove that they're at a unique risk of injury compared to adults? Are they getting injured at this lower level? So the purpose of this research was to compare youth and adult impact characteristics using dynamic response values and brain tissue deformation in real-world reconstructions of PCS injury. So our data was collected from several large urban hospital emergency care centers all across Canada. For the adult category, we used 11 subjects, which were all aged 18 years and older. The youth category was ages 6 to 8 years, and 11 subjects were within that category as well. All the patients were diagnosed with post-concussive syndrome, meaning that after 4 weeks they had 3 or more symptoms that were residing. All subjects included in this study impacted their head on concrete, and they were all mechanism of a fall. So all of our subject cases were separated into impact location and defined as front, side, or rear impacts. The front were categorized as the anterior intersection of the mid-sagittal and absolute transverse plane. The side was the midpoint between the anterior mid-sagittal and the right coronal plane in the absolute transverse plane. And the rear was the posterior intersection of the mid-sagittal and absolute transverse plane. So as you can note, you can see that there is differences in the velocity. There is an average difference of 0.08 meters per second between the children and the adult, with the youth being at the lower velocity. So patients were only included if the patient or a witness had a full recall of the events which occurred. So this included the impact velocity, the head impact location, the impact surface, and the impact geometry. So all of these characteristics were filled out on an impact injury report that was filled out by the ER physician. What is important to note on this form is that the mass, the impact location, as well as velocity and impact surface, which was separated by mechanism. So first we used these reports and we reconstructed using a mathematical model to gain the impact velocity. This was used as we had no video recall of the events. So this fall reconstruction determined an acceptable range of possible impact velocities using the parameters given on the impact report. So what we did, as you can see in the picture, is we determined a range of possible velocities. So as fast as they possibly could have hit, therefore with no arms, and as slow as possible where they had tried to block their fall with their arms. In these reconstructions, we used the lower velocity to make sure that we didn't miss the threshold risk of injury. So by getting the inbound velocity, we then used this into a physical model, and we reconstructed each patient case. So we used a 50th percentile hybrid 3 male head form for all adult cases, and a 6-year-old hybrid 3 head form for all youth cases. Both head forms were then attached to an unbiased neck form and equipped with a 3x2x2x2 accelerometer array. So from this, we then attached the neck form to a monorail drop brake. We impacted all the head forms on a concrete surface so that it was consistent between all trials. We set the monorail drop brake to drop at the corresponding impact velocity found from the mathematical model. The accelerometers then captured data for linear and rotational acceleration. We then used these outputs as inputs into our finite element model, which was the University College of Dublin brain trauma model. So this trauma model uses dynamic response input data collected from the head form and then uses it to determine a representation of the strain experienced by the brain tissue during this impact. Is it important to note that the model was scaled for the youth cases? So a t-test statistical analysis was run for all trials between the youth and the adult category, and significance was accepted at 0.05. So as you can note that the youth was significantly lower than the adults in both the linear and the rotational acceleration. As you can see, there is a large standard deviation for the rotational acceleration in the youth category. And this is because 2 out of the 3 side impacts reached over 35,000 radians, whereas it was an average of under 10,000 for the rest. Continually, there was a significant difference also found in velocity as well as the maximal principal strain, as the youth was significantly lower than the adults for both of those variables as well. Therefore, as you can note, the youth PCS reconstruction cases produce significantly lower inbound velocity, peak linear, and peak rotational acceleration values, as well as maximum principal strain. Interestingly, there was a percent differences between the child and the adults were very similar for all variables. The children were 36% different than the adults for both linear and maximal principal strain, and 32% difference in rotational acceleration. So therefore, this may lead us to believe that the youth are at a unique risk of concussion, as persistent concussion, as they are getting injured at a much lower dynamic response in brain tissue deformation level. This could possibly be explained by biological differences. Because of their height, the children are closer to the ground and have smaller mass. However, they're still getting injured, which leads us to believe that they may be more susceptible to injury because of a decreased brain tolerance to the mechanical stress of the injury. Therefore, this research does lead us to show that there is a unique risk in youth compared to adults. Therefore, lower dynamic response values were shown, which may mean that they are more susceptible at lower levels. This is particularly important when we look at equipment development, especially in helmet designs. Currently, there is a pass or fail standard, and that threshold of injury is based on adult data. So to speak to this, if there is a lower threshold for youth, it may be a possibility that we may need to consider this a special risk category when developing things for youth specifically. So in conclusion, the youth may be at a higher risk of persistent concussive syndrome injury because of their biological differences in terms to adults. It is therefore very important to take lower values into consideration when evaluating the child's risk within an environment, specifically when determining protective equipment and game regulation. So furthermore, this information can be used to develop management and treatment programs more specific to persistence and for different severities of concussions within youth. Thank you, and any questions?